Hello, my name is Dr. Banik, and I am Associate Professor of Ophthalmology at New York Eye and Ear Infirmary of Mount Sinai. Today, I will be speaking to you about eye care for the elderly. I have no financial or commercial interests related to the content of this talk. The demographics within the United States, as well as within the world, are changing. People are living longer, healthier lives. As a result, the percentage of the population which is elderly is steadily increasing. For the purposes of this talk, I will be referring to the elderly as persons aged 65 and above, as defined by the World Health Organization. On this slide, you can see a graph of the rising elderly population within the United States from the year 1900 projected to the year 2030. The graph shows that the number of elderly persons aged 65 and above is steadily growing with an expected population of almost 55 million projected for 2020 and 72 million as projected for 2030. Correspondingly, the life expectancy within the United States as well as in other countries is steadily increasing. You can see from this graph that in the late 19th century, average life expectancy was approximately 47 years. This number has been steadily climbing, and in the year 2015, life expectancy within the United States is estimated to be 79 years. As the elderly population grows, we must be aware of some of the health issues which can arise during the later years. Vision loss in the elderly is quite common. In fact, 1 out of 3 persons have some degree of vision loss by the age of 65. Vision impairment can affect quality of life in many ways. Impaired vision can lead to consequences such as restriction of daily activities, decreased mobility, higher risk of falls and fractures, social isolation, and depression and loss of independence. As we all get older, our visual acuity does tend to decline. The risk of visual impairment increases and the prevalence of legal blindness also increases. On this chart, the largest letter, the E, represents 2200, and the bottom line represents 2020. When a person cannot read the top letter E, that is considered legal blindness. Unfortunately, vision impairment often goes untreated, especially in the elderly population. According to one study, the 3 leading causes of blindness in the elderly within the United States included unoperated cataracts, primary open-angle glaucoma, and age-related macular degeneration. Potentially 1/3 of blindness caused by these conditions is avoidable with early diagnosis and treatment. With proper care and routine ophthalmologic examination, we can help maintain normal vision, as we see on the right of this photograph. We also can potentially help prevent severe blurred vision or visual impairment, as we see on the left. Thus, early diagnosis and treatment can have a tremendous positive impact on one's quality of life. Currently, within the United States, there are 4 leading causes for vision loss in the elderly. These include 1. Age-related macular degeneration, 2. Glaucoma, 3. Cataract, and 4. Diabetic retinopathy. During the remainder of this talk, I will review each of these conditions, their associated symptoms, findings on exam, and management. First, I would like to discuss age-related macular degeneration, also referred to as ARMD or AMD. Within the United States, it is the most common cause of vision loss in the elderly. In age-related macular degeneration, there is loss of central vision with preserved peripheral vision. Risk factors include advanced age, usually greater than 70 years, fair skin, family history of macular degeneration, smoking, and heart disease. These images depict what it may be like to have macular degeneration. The photograph on the left is what a person with normal vision would see. Note the bright colors, central clarity, and intact peripheral vision. In the photograph on the right, however, there is a central area which is obscured, and surrounding that dark area, the vision is quite blurry as well. The colors remain relatively intact in the periphery. There are 2 types of age-related macular degeneration, dry and wet. Both can be diagnosed with a dilated fundus exam, which should be performed by an ophthalmologist at least on an annual basis. This slide depicts normal retina on the left, in which we see the optic nerve in the center, which is a circle, yellowish-orange in color. We can also see the blood vessels stemming from the optic nerve, the central part of the retina called the macula. The photograph on the right depicts an eye with dry macular degeneration. Here, you can see that there are multiple yellow spots. These spots are called drusen. Drusen are deposits underneath the retina. As these spots coalesce, vision loss may develop. The progression of drusen tends to be quite slow over many years, though advanced stages of drusen may result in significant vision loss. This slide depicts wet macular degeneration. In this condition, vision loss is more sudden and severe, caused by acute bleeding under the retina. As you can see here, there is fresh blood in the macula. Along with blood, there is leakage of fluid, which leads to decreased vision. Usually, patients with many drusen are more at risk for wet macular degeneration. With regards to symptoms of macular degeneration, in the earlier stages, patients may have difficulty with reading or driving. When looking at straight lines, they may appear crooked or distorted. This image depicts what a person with visual distortion from macular degeneration may see when looking at a door. This slide demonstrates another example of visual distortion from age-related macular degeneration. As macular degeneration becomes more advanced, patients may develop a central blind spot with intact peripheral vision. With loss of central vision, independent living skills are significantly restricted, including reading, driving, and other myriad of tasks. This slide depicts how one may monitor for the changes associated with macular degeneration. This is called an Amsler grid. It is a card with a grid pattern and a central fixation target. This card should be held at reading distance of approximately 14 inches. One should look at the center dot with each eye, or one eye at a time. When looking at the central dot, one should be able to make out all four corners of the large square and all the smaller squares within. If there is any area of distortion, as we can see here, or a blind spot, also seen here, that may signify pathology within the retina, which may be macular degeneration. With regards to reducing the risk of macular degeneration or the progression of dry early macular degeneration to more severe vision loss from wet macular degeneration, monitoring vision daily with an Amsler grid is recommended. Also, it is recommended that the patient cease smoking and control other risk factors, including heart disease and monitoring of blood pressure. A diet high in fruits and vegetables also may help lower the risk, particularly those foods rich in antioxidants. It is also believed that certain supplements such as lutein, zeaxanthin, resveratrol, and saffron may be beneficial in slowing the progression of dry macular degeneration. If age-related macular degeneration is diagnosed, one should follow up with a retina specialist on a regular basis for monitoring. Special testing may be necessary. Further treatments for macular degeneration are beyond the scope of this talk, though may include laser, injections, or other forms of therapy. Should you have further questions regarding macular degeneration, please be sure to ask your ophthalmologist or ask for a referral to a retina specialist. Next, I will be talking about glaucoma. Glaucoma is the second most common cause of vision loss in the elderly. In the United States, it is believed to affect at least 10% of African Americans greater than 70 years of age and 2% of the Caucasian population greater than 70 years of age. However, these numbers are likely an underrepresentation of the true prevalence of glaucoma. We know that with glaucoma, early detection and treatment can help prevent blindness. So, what is glaucoma? Glaucoma is optic nerve damage associated with peripheral vision loss. Glaucoma may or may not be associated with high eye pressure. Please note that eye pressure is different from blood pressure and is checked during your routine ophthalmologic examination. So how is a person's vision with glaucoma affected? In this slide on the left, we see an image seen by a patient with normal vision. On the right, we see the same image as seen by a patient with glaucoma. In glaucoma, central vision tends to be preserved, but there is peripheral loss or constriction. In the most advanced stages of glaucoma, a patient may see only tunnel vision. This is in contrast to age-related macular degeneration, as we just discussed, in which the central vision is affected first. If glaucoma is suspected, several in-office tests are performed by your ophthalmologist. These include checking the eye pressure, which again may or may not be high, checking a visual field test, and looking at the optic nerve for damage, also called cupping. Though eye pressure may be checked in multiple ways, the gold standard is to use a device called an applanator, as we see in this photograph. The eye is first anesthetized with drops. The tip of the device touches the surface of the eye and helps to read the true pressure of the eye. It is important that a patient not squeeze his or her eyelids shut when this test is performed, and the examiner also not put pressure on the eye, which may result in a falsely elevated pressure. This slide shows a patient performing a visual field test. A visual field test is performed within a machine in which the patient's face rests on a chin rest. Within the machine, the patient is shown circles of light. When the lights are seen by the patient must respond by pressing a button. The machine then analyzes the patient's responses to determine if there is any loss of peripheral or central vision. This slide depicts the damage which may occur to the optic nerve from glaucoma. The diagram on the left depicts a normal optic nerve or optic disc, which is round with blood vessels stemming from the center. Within the center, there is a clear area, which is whitish yellow in color. This clear area is called the optic cup. The ratio of the area of this cup compared to the area of the full optic disc is called the cup-to-disc ratio. A normal cup-to-disc ratio is 0.4 or less. The diagram on the right shows an optic nerve affected by glaucoma. Here, we see that the central optic cup is significantly enlarged with a cup-to-disc ratio of approximately 0.8. This disc appearance is classic for glaucomatous changes. In addition to the cup-to-disc ratio, ophthalmologists look for other findings which may indicate glaucoma. In this image, we see a moderate-sized cup with a notch or thinning at the bottom of the optic nerve. Normally, the optic cup is usually round, so if there is an area where the cup is elongated, that may signify damage in that area. The ideal way to visualize an optic nerve is to perform a dilated examination. After dilation, the nerves may be imaged with lenses or an ophthalmoscope. This picture is depicting a direct ophthalmoscope, which the examiner is using to view the patient's optic nerve. Though there are many types of glaucoma, there are two large categories: open-angle or closed-angle glaucoma. The term angle refers to whether the drainage system of the eye is open or closed. Open-angle glaucoma is the most common type in the elderly and is usually treated with medications, whether that be drops and/or pills. Surgery may become necessary at later stages. Closed-angle glaucoma may occur with increasing age, but there is also a higher risk in Asians, females, and those who are farsighted or hyperopic. Patients with closed-angle glaucoma or those who are at risk for closed-angle glaucoma may require medications and/or laser treatment. With regards to symptoms in open-angle glaucoma, it is usually asymptomatic in the early stages. However, if undiagnosed and left untreated over many years, it can lead to blindness. The prevalence of open-angle glaucoma is related to age and increases as both men and women become older. Aside from age, another major risk factor is race. We know that patients who are of Black race have a higher prevalence of glaucoma, with the risk of blindness being 3 to 4 times greater. There is a 10% prevalence amongst those who are Black and above the age of 70, compared to a 2% prevalence amongst those who are Caucasian above the age of 70. Also, open-angle glaucoma tends to occur at an earlier age in blacks, and it also tends to be more advanced when discovered. Other risk factors for open-angle glaucoma include positive family history and other factors such as high myopia, history of high blood pressure, cardiac disease, and diabetes. In closed-angle glaucoma, the patient groups who are at higher risk include the elderly, Eskimos, Asians, females, nearsighted patients, and those with a positive family history of closed-angle glaucoma. In closed-angle glaucoma, the risk of having an acute attack which is symptomatic is much greater than in open-angle glaucoma. Symptoms of acute closed-angle glaucoma include severe eye pain and redness, blurred vision, halos around lights, headache, nausea, and vomiting. This photograph depicts an eye with closed-angle glaucoma. Closed-angle glaucoma is considered one of the true emergencies in ophthalmology. We can see here that the entire eye is red, 360 degrees, and the pupil is neither large nor small, but mid-size. If the eye pressure is high, then the patient likely has closed-angle glaucoma. The eye pressure must be reduced as soon as possible before any permanent damage affects the optic nerve. Glaucoma is usually treated with eye drops and/or pills to help lower the eye pressure. Many of these medicines can affect the autonomic nervous system and can impact blood pressure, heart rate, or the airways within the lungs. Glaucoma medicines may have numerous side effects, and these side effects may be more pronounced in the elderly, so they must be prescribed with caution. This slide depicts some of the glaucoma drops which may be used to lower eye pressure. Some patients with glaucoma may require more than one type of drop to control their eye pressure. Dosing of various drops may also vary, ranging from once a day to 4 times a day. Note that each group has a cap of a different color, which may help patients in identifying which drops they need to take and how often. In order to reduce or prevent some of the side effects of glaucoma drops, the technique shown here may be helpful. This is called punctal occlusion. After instilling a glaucoma drop, applying pressure with the fingers to the eyelids by the nose for 3 to 5 minutes will reduce absorption of the drop into the bloodstream and may help reduce some of the side effects. This slide shows some of the oral medicines used in the treatment of glaucoma. Oral medications tend to be reserved for more advanced cases of glaucoma, particularly those cases in which drops alone are not sufficient to control the disease. Each of these medications may have side effects, which a patient should discuss in detail with their treating ophthalmologist. Next, I will be talking about cataract. Cataracts are the third leading cause of blindness in the elderly. Cataracts may occur at any age from birth through late adulthood, though they are much more common with advancing age. In fact, everyone will develop some degree of cataract if one lives long enough. Cataracts are responsible for decreased vision in 18% of persons aged 65 to 74, and in 46% of persons aged 75 to 84. So, what is a cataract? We all have a natural lens inside of our eye which helps us focus at both distance and near. When we are young, this lens is clear or transparent. With increasing age, the lens becomes yellow or cloudy, as we can see in this cross-sectional diagram of the eye. When the natural lens becomes too cloudy or opacified, this is called a cataract and may lead to decreased vision. In this image, we see on the left what a person with normal vision would see. On the right is an example of what a person with a cataract may see. The entire image is blurred and colors may appear not as bright or muted. In the early stages of cataract, the visual disturbance may be only mild. However, as the cataract progresses, vision loss may become more significant. The size and location of the cataract also determine the symptoms of how vision may be impacted. There are many different types of cataracts. This image shows a range of types of cataract. The image on the upper left is a yellowish cataract. The one on the upper right has white flecks. The image on the lower right is a mature, completely white cataract. And finally, the image on the lower left is a spoke-like cataract. Each of these types of cataracts may impact vision in different ways and produce symptoms such as glare, decreased distance vision, decreased near vision, a dark area in the central vision, or even complete loss to the level of legal blindness. It is not uncommon for a patient to have a combination of these types of cataracts. With regards to the treatment of cataract, there is no scientifically proven way to prevent a cataract or treat it with medication. The only proven successful treatment is removal of the cataract surgically. Surgery may be indicated if the cataract is causing significant visual impairment by affecting one's activities of daily living, such as driving, reading, watching television, sewing, cooking, etc. Cataract surgery should be done in consultation with the patient's primary care doctor. The patient must be healthy enough to undergo elective surgery. Cataract surgery is an outpatient surgery. It is performed one eye at a time. Local anesthesia, in the form of either drops or an injection, is used with sedation. Most cases require no stitches. In the United States, cataract surgery is performed in an operating room under a microscope. The vast majority of surgeries are performed using an ultrasound machine to break up and then remove the cloudy lens. Laser-assisted cataract surgery is a relatively new procedure and is becoming more available. Once the cataract is removed from the eye, a clear lens implant is placed to help the patient focus. This implant may be made out of an acrylic or silicone material. This implant is placed inside the eye, so it is not readily visible. The implant remains with the patient for life. The outcome of most cataract surgeries is excellent, with over 90% of patients seeing 20/40 or better, as long as there are no other eye diseases present. There are, however, risks to consider, as with any kind of surgery. Though rare, these risks include infection, glaucoma, and retinal detachment, to name a few. A detailed discussion regarding specific risks and benefits should take place between the patient and his or her ophthalmologist prior to cataract surgery. The fourth and final topic which I will be discussing today is diabetic retinopathy. Diabetic retinopathy is the fourth leading cause of vision loss in the elderly. It is more commonly seen in type 2 diabetics. A patient with diabetic retinopathy may develop bleeding inside the eye, protein deposits, or swelling of the retina, known as diabetic macular edema. In this image on the left, we see how a person with normal vision would see. On the right, we see what a person with advanced diabetic retinopathy may see. There are several dark patchy areas which are missing within the central vision, with generalized blurring in between. In this slide, we see what a retina with diabetic retinopathy looks like. There are yellowish protein deposits which have leaked out of the blood vessels within the eye. When the deposits are associated with swelling in the retina, this is called diabetic macular edema and can cause significant vision loss. This picture shows the optic nerve or optic disc with thin, fragile blood vessels overlying it. These blood vessels grow in cases of advanced diabetic retinopathy. These abnormal blood vessels are harbingers of severe vision loss should they bleed. Diabetic retinopathy is best managed by a retina specialist. There are various treatment options including laser and/or injections into the eye. Prevention, control, and management of diabetic retinopathy is closely linked with control of blood sugar. Therefore, it is critical that the patient, primary care physician, and ophthalmologist work together to help regulate blood sugars tightly. This may be accomplished with a combination of medications, pills and/or insulin, diet, exercise, and weight loss. In summary, it is expected that with age, vision decreases. There are specific common eye conditions which affect the elderly. If untreated or advanced, these conditions may cause significant visual impairment. However, many of these conditions are treatable. To improve or maintain visual function, it is important to have regular screening eye exams, at least on an annual basis, for any person above the age of 50. It is also important that there be coordination between the patient, ophthalmologist, and the primary care doctor to ensure the best care. As we all get older and hope to lead long, healthy lives, it is crucial that we keep our eyes healthy as well, so that we can fully enjoy our years ahead. I would like to thank you for your attention. I hope that this presentation has been informative. For additional information about any of the eye conditions discussed in this talk, or to find an eye physician who can help you take care of your eyes for a long, healthy life, please visit our website at www.nyee.edu. Thank you again.